Selamat pagi, selamat datang kepada yang kami cintai, seluruh sivitas akademika Widya Mandala, dekanat, dosen, dan kepada para dokter dari Rumah Sakit PHC, mahasiswa-mahasiswi Fakultas Kedokteran Widya Mandala yang telah hadir pada acara Essential Learning pada pagi hari ini. Good evening to our speaker, Profesor Anthony Setiawan from Dallas, Texas, USA. Perkenalkan, saya Dr. Sianti Dewi. Hari ini akan memandu jalannya acara pada kegiatan Essential Learning. Kepada para peserta, kami himbau untuk menyalakan kamera dan mematikan mic selama acara berlangsung. Sebelum memulai kegiatan hari ini, izinkan saya untuk mengawali acara dengan doa. Doa akan dipimpin oleh Dr. Ivan. Kepada Dr. Ivan, kami persilahkan.
Selamat pagi semuanya, Prof. Antoni, Dr. Sianti, dan dokter-dokter yang lain yang sudah hadir, dan teman-teman sejawat, jadi mahasiswa-mahasiswi. Pada pagi hari ini saya akan melakukan doa pembukaan untuk memulai acara pada pagi hari ini. Saya mohon izin untuk memimpin secara Kristiani, yang lainnya dapat mengikuti. Mari kita mulai. Tuhan Yesus, terima kasih ya Tuhan atas pagi hari ini, anugerah-Mu kepada kami ya Tuhan. Kami boleh diberikan kesempatan untuk berkumpul bersama-sama dalam acara Essential Learning yang kedua ini. Tolong ya Tuhan, berkati kami semua ya Tuhan, sebagai host, sebagai moderator, sebagai speaker, maupun kami sebagai pendengar, agar semuanya Tuhan bisa pakai kami ya Tuhan dalam segala keterbatasan kami, agar kami dapat menyerap, bisa menyampaikan materi pada pagi hari ini pun dengan yang terbaik ya Tuhan, dan biarlah semuanya itu bisa kembali lagi ya Tuhan untuk memuliakan nama-Mu. Kami serahkan ya Tuhan acara ini dari awal sampai akhir hanya ke dalam nama-Mu. Hanya dalam nama Tuhan Yesus kami berdoa dan mengucap syukur. Amin. Terima kasih dokter.
Terima kasih atas doa yang sudah dibawakan oleh Dr. Ivan. Semoga sesuai dengan harapan tersebut, hari ini kita bisa belajar banyak dari Profesor Anthony dan bisa bersama-sama berdiskusi untuk mendapatkan banyak hal yang berguna bagi kegiatan kita di masa depan. Kita akan lanjutkan dengan menyanyikan lagu Indonesia Raya, diikuti Mars Fakultas Kedokteran Universitas Katolik Widya Mandala Surabaya. Para peserta dimohon untuk mengambil posisi sempurna. Kami persilahkan. Mohon maaf, mungkin ada sedikit gangguan di audio. Mungkin bisa diulang untuk lagu Indonesia Raya.
Indonesia, tanah airku, tanah tumpah darahku. Di sanalah aku berdiri, jadi pandu ibuku. Indonesia, kebangsaanku, bangsa dan tanah airku. Marilah kita bersatu, Indonesia bersatu. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya untuk Indonesia Raya. Merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku, negeriku yang ku cinta. Fakultas Kedokteran Widya Mandala, Konseling Serviterissimus, majulah terus. Pancasila dalam hidupku kita amalkan, untuk sesama kita, untuk nusa dan bangsa. Dokter profesional berspiritualitas, berintegritas moral, berdisiplin, soft skill prima, belajar bersinambung dengan etika dan sopan santun, kami layani sesama. Fakultas Kedokteran Unika Widya Mandala, Fakultas Kedokteran Unika Widya Mandala.
Terima kasih. Acara akan kita lanjutkan dengan sambutan dari Dekan Fakultas Kedokteran Universitas Katolik Widya Mandala kepada Prof. Paul Tahalele. Waktu kami persilahkan.
Selamat pagi dan untuk kita semua, dan selamat malam untuk Prof. Anthony yang ada di Texas. Rupanya kita ini secara pelan-pelan sudah mulai di Indonesia ya, Prof. Anthony. COVID sudah banyak menurun dan semoga tidak outbreak lagi ini. Puji syukur kehadirat Tuhan Yang Maha Kuasa bahwa sampai saat ini kami atau kita semua masih diberi kesehatan yang cukup dan juga kesempatan untuk berbakti di Fakultas Kedokteran Widya Mandala ini, dan juga para mahasiswanya yang sekarang sudah mulai secara bertahap untuk mengikuti kuliah-kuliah secara offline. Selamat pagi Dr. Puji Enuarto. Terima kasih atas kehadirannya, juga atas sambutannya nanti. Terima kasih juga kepada Dr. Epri yang akan memimpin membawa acara ini sebagai moderator. Kemudian Dr. Syanti yang menggantikan Dr. Dev. Ini semuanya adalah hasil kerja kita semua dan juga para panitia DS yang telah bekerja luar biasa. Dan juga pada sejawat kami, Dr. Antoni. Dr. Antoni ini, Prof. Antoni adalah 1 tahun di atas saya. Jadi temannya Profesor Sunario Arjowinoto yang baru saja pass away ya, meninggal. Prof. Sunario ini spesialis urologi juga bekerja sebagai salah seorang spesialis urologi di Rumah Sakit PHC Surabaya. Pada kesempatan ini adalah kuliah tamu khusus yang kedua dari Prof. Antoni. Mari kita dengarkan dengan baik, terutama pada para mahasiswa, karena bagaimanapun juga dengan teknologi internet yang kita manfaatkan sekarang ini, kita bisa saling mengetahui atau mendengar apa yang terjadi di dunia luar, dan khususnya untuk juga membuka wawasan para mahasiswa terhadap kemajuan teknologi yang ada di luar. Mungkin saja satu saat Anda sekalian juga bisa untuk ke luar negeri. Oleh karena itu rajin belajar, mempunyai ilmu, mempunyai skill, juga harus banyak juga menulis ya, seperti Prof. Antoni banyak menulis sehingga dia menjadi seorang guru besar. Juga kami sendiri mengalami demikian. Harus semangat, harus punya antusias yang tinggi untuk belajar dan mencapai cita-cita menjadi dokter yang baik. Saya kira itu dari saya, dan saya kira once again, Profesor Antoni, thank you very much for your kind helps to us, our medical faculty, Widya Mandala, Surabaya Catholic University. Thank you, Profesor Antoni, dan pada semua hadirin, para mahasiswa yang saya cintai, tolong diperhatikan, disimak yang baik ya. Mungkin terlalu spesialistis, tapi maksud kami yang pertama adalah membuka wawasan Anda semua. Terima kasih, semoga semua dalam keadaan sehat walafiat dan salam sejahtera.
Terima kasih atas sambutan yang telah diberikan oleh Prof. Paul Tahalele. Berikutnya kata sambutan akan diberikan oleh Kepala Rumah Sakit PHC, Rumah Sakit Pendidikan untuk Universitas Katolik Widya Mandala. Kepada Dr. Puji Januartono, waktu kami persilahkan.
Terima kasih, pembicara. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi buat yang Indonesia dan selamat malam buat Prof. Antoni. Pertama-tama, marilah kita panjatkan puji syukur kehadirat Allah SWT bahwa pagi hari ini kita semua masih diberi nikmat sehat, nikmat waktu, sehingga bisa berkumpul, belajar bersama untuk meningkatkan ilmu dan wawasan kita. Apresiasi kami dari Rumah Sakit PHC Surabaya buat Prof. Paul dan juga FK Widya Mandala bahwa semangat belajarnya yang tiada henti, tiada putus, ini bisa membawa kebaikan buat kita semua. Juga di sisi lain, ada manfaat dengan kerjasama ini untuk pengembangan pelayanan yang ada di Rumah Sakit PHC. Jadi semua hal luar biasa, kami apresiasi, baik dari sisi semangat belajar, dari FKWM, juga dari kerjasama ini untuk peningkatan pelayanan yang ada. Sekali lagi selamat berwebinar, mudah-mudahan Allah Ta'ala memudahkan dan meridhoi apa yang kita kerjakan hari ini. Terima kasih, mohon maaf. Saya akhiri dengan ucapan Alhamdulillah. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi.
Terima kasih kepada Dr. Puji Januartono atas sambutan yang diberikan. Acara selanjutnya akan dipimpin oleh Dr. Eprianto Darmadi, spesialis radiologi dari Rumah Sakit PHC. Sebelumnya, saya mohon izin untuk sedikit membacakan kurikulum vitae beliau. Mungkin sudah sangat tidak asing buat kita semua karena Dr. Eprianto adalah salah satu dosen di Fakultas Kedokteran Widya Mandala untuk Departemen Radiologi. Beliau menyelesaikan pendidikan dokter dari Universitas Gadjah Mada tahun 91, kemudian pada tahun 2006 menyelesaikan spesialis radiologi dari Universitas Airlangga. Beliau aktif bekerja di PHC sejak tahun 1996 dan pada tahun 2006 bekerja di Departemen Radiologi Rumah Sakit PHC. Kepada Dr. Eprianto, waktu dan tempat kami persilahkan.
Terima kasih Dr. Sianti Dewi. Selamat pagi semua. Yang terhormat Prof. Paul Thalis, spesialis BTKV sebagai Dekan Fakultas Katolik Widya Mandala. Kemudian Dr. Puji Januarto Mars sebagai Kepala Rumah Sakit PHC Surabaya. Kemudian kepada Prof. Antoni Setiawan PhD yang sebagai pembicara seminar kali ini. Dan para dari dekanat, para dosen, dan para sejawat sekalian, dan yang tidak saya bisa sebutkan satu persatu. Dan juga selamat pagi semua kepada seluruh partisipan seminar ini. Selamat datang di acara The First Essential Learning Series Second. Saya Prianto sebagai moderator pada seminar kali ini. Saya sangat senang sekali dapat membawakan topik tentang radiologi, khususnya kali ini tentang the role CT scan abdomen, CT scan in abdominal imaging ya. Kita sudah tahu semua, jadi pemanfaatan CT scan sudah banyak dan luas dalam imaging pada diagnosis kelainan pada abdomen. Jadi kesempatan ini sangat bermanfaat bagi kita semua ya. Mungkin sebelumnya saya akan membacakan kurikulum IT pada pembicara saat ini, yaitu Prof. Antoni Setiawan ya. Beliau sempat mengenyam pendidikan di FK UNER 1972 dan selanjutnya sebagai asisten profesor di Departemen Anatomi. Selain itu, beliau juga mengenyam pendidikan dalam lingkup radiologi di University of Texas dan untuk mengembangkannya juga sampai saat ini masih aktif di institusi Rumah Sakit Saint Paul University Hospital, CLC University Hospital, Parkland Health and Hospital System, dan Human University Hospital yang secara keseluruhan di Dallas, Texas. Selain itu, beliau juga memperoleh jabatan-jabatan yang mengagumkan ya di lingkup seperti di Director Ultrasound Preceptor Program, Moderator, Director Abdominal Imaging Fellowship Program, dan di Director Abdominal Imaging Division. Ya. Untuk sebelum pemaparan dimulai, izinkan saya menjelaskan bagaimana jalannya seminar kali ini. Pertama nanti Prof menyajikan materi kurang lebih dalam waktu 40 menit. Kemudian dilanjutkan dengan sesi tanya jawab. Para audiens berkenan untuk menyampaikan pertanyaan lewat chat, kolom chat, atau mungkin video raise hand. Nanti dilanjutkan dengan sesi tanya jawab setelah dan materi selesai. Mungkin untuk menyingkat waktu, kami persilahkan Prof. Antoni Setiawan PhD untuk menyampaikan materi. Saya persilakan Prof. Antoni Setiawan menyampaikan materi. Waktu saya serahkan sepenuhnya.
Oke, ya. Screen-nya bisa kelihatan ya?
Kelihatan, Prof.
Oke, suaranya masuk enggak?
Jelas, Prof.
Oke, good. Ya, selamat pagi untuk mahasiswa-mahasiswi dari BC Mandala dan teman-teman sejawat. Terima kasih pada Dr. Tarmadi untuk introduction. Terima kasih juga untuk Prof. Tahalili yang memberi kesempatan saya untuk membagi pengetahuan saya selama berada di United States. Pagi ini saya mau bicara tentang CT scanning of the abdomen. Tapi karena bidangnya ini luas sekali, jadi saya pilih topik-topik yang semoga bisa ambil interest untuk para hadirin. Dan seperti lecture saya yang lalu, 3 minggu yang lalu, dilemanya ini adalah hanya mixed audience. Jadi semoga ini presentation ini cukup balance untuk mahasiswa-mahasiswa dan juga untuk para hadirin yang lebih berpengalaman tentang CT seperti Dr. Tarmadi. Dan seperti lecture yang lalu, untuk saya lebih smooth, lebih mudah untuk memberikan ini dalam bahasa Inggris. Jadi saya maafkan kalau ini saya haruskan ucapkan dalam bahasa Inggris. So ini topik-topik yang kita pagi ini kita bicarakan adalah ini, city listed. Dan kita mulai dengan topik pertama. How do we compare radiographs and CT? CT is basically a computerized tomogram. 50 years ago, when I was a resident, I was still working with plain radiographic or X-ray tomogram. Tomogram is basically finding a plane, a coronal plane of a patient, and at the time was done mechanical. By blurring all the other planes and leaving the plane of interest in focus. So the computerized tomography, like it said, is done by computer. And with the advancement of the computer, the CT has really changed from the beginning. As a comparison, or you can imagine when CT first was introduced, it took about 12 hours to reconstruct one slice of the head. And nowadays, we can scan the whole abdomen, for instance, in 10-15 seconds in one breath hold. And the concept of how these images are produced is also entirely different. So this is an X-ray. So this is a picture of a patient lying supine. And basically on X-ray, we send a beam of X-ray and put a film over here as a receptor. And the result is something like this, where all these structures are seen, but they're all on top of each other. Because there's no separation between the liver, gallbladder, and the kidney behind it here. The resolution of density is also quite limited. For instance, we cannot differentiate fluid from soft tissue. We can see gas here, but bone and a soft tissue in between, but we cannot differentiate fat from soft tissue. Fluid-filled bowel loops can also not be visible. So the imaging, so the information is very limited. CT scan, as you see here, there's a CT machine over here. Sort of have the same concept, but the result is different. So here we have the X-ray also, and the beam here is very thin. The machines that we use now has a beam that is only about 0.5 millimeter thick. And instead of a film here, we put a bunch of detectors, very sensitive detectors, and the X-ray beam is going to be moved around, and the detectors also move around in a circle in the opposite direction. So basically, this patient is going to be looked at from all different angles, 360 degrees. And the result is something like this. So this is an axial or transverse image. And here you can see that we no longer have to deal with organs that are on top of each other. We can see each organ separately, stomach, gallbladder, liver, and the kidney. We can also tell the difference density between all this soft tissue. This muscle is a different density than the liver, for instance. And also we can recognize fat, and the fat is a nice friend for CT because we can separate all these structures by having fat. The next topic is a display of CT. So this is what we call an axial transverse image. This is basically the image that we see in the beginning of the scan. And this is what we call a soft tissue setting. So here we concentrate on the soft tissues. The air is just all black, the bone is all white, but I have a nice definition of all the soft tissues, separate them easily. If I want to concentrate on lung, we just change a few settings and we get the lungs. So now we see, instead of just a black space, now we see all small structures, all small vessels, those little bronchi, and hopefully if there's any small nodules or other subtle pathology, we can pick it up at the same time. Soft tissues and bone are ignored. Now I'm going to concentrate on the bones. Now we ignore the soft tissue and the air, and we have some nice details of the bone. You see the trabecular pattern of the vertebral body, for instance, so that there's subtle lesions, then we can pick it up that way. We can also look at some other plane. So this is all done by computer, almost instantaneously, with just a few seconds. I can have all the pixels line up in this plane here and produce an image like this. So this is a coronal image. This is a 4 millimeter thick slice. The original data is 0.5 millimeter. So we do not want to see like thousands of images. So we have 8 of these 0.5 millimeter images bunched together and produce this coronal image. If I want to look at a different plane, say I want to see what happened here, we just move this line here, and then we have an image like this. I also can do a sagittal reconstruction. So say I want to have all these pixels in this plane line up to the superior mesenteric artery, or the SMA and the aorta, then we end up in an image like this. So here we have the aorta and the SMA. Okay, so these reconstruction images are very useful for a surgeon, for instance, when they do surgery, and for radiologists also very important. Often we have trouble figuring out where this organ is coming, where this mass is coming from, or where the extent of it is, and this reconstruction is certainly a big help. We can also do reconstruction in space, a 3D reconstruction. Okay, so I can pick out a certain density like the bone and have all these pixels reconstructed in 3D. So this is, for instance, is a 3D reconstruction of the skull. And we can look at it from all different planes. So I can rotate this head. We can look at also like a water's view from the bottom here. And this is very useful for surgical planning for orthopedic surgeons. So for instance, here is a very complex fracture. And before the orthopedic would do surgery, it will be a nice roadmap to plan the surgery, or what to do and which one area to fix. Looking at vessels, so this example is the heart. We have the heart, all the different density, they have the different color code. We see all the vessels here. I can pick out a certain vessel and line it up. So for instance, this branch here, so all this is called oblique reconstruction, where all these pixels along this vessels are lined up like this. I can just isolate it, look at this vessel, or I can get rid of all the soft tissue and only look at the vessels. Talking about vessels, we can inject contrast. We're going to talk about contrast enhancement a little bit later. But with injecting contrast, which is contain iodine, and iodine has a high density, I can light up the arteries and get what we call a CTA, with a CT angiography. So nowadays, a lot of these angiographies are no longer done with catheter. We simply give a bolus of injection intravenously, and then scan during the time where the contrast is in the arteries, and then scan very quickly. So we can, for instance, and we can actually do the entire body. So we can just concentrate in the head to get the head CTA. If I want looking at the renal arteries, we just concentrate in this area. If I want to look at the lower extremity, we can see all these vessels all the way down to the toes. And we can also get a surface reconstruction. Okay, so this will be very useful for plastic surgeons, for instance. So that's the display that we can achieve with a CT. Certainly cannot be done with a radiograph. Okay, so talking about density, with CT, we can also classify the density. And this is done by obtaining Hounsfield units. So a little bit about Hounsfield. It's from a Godfrey Hounsfield. This is one of the main person that developed the CT. And with that, actually, he got a Nobel Prize for physiology in, I think, in '79. And he also developed this chart of different Hounsfield units. So the Hounsfield unit described the type of density. Air, for instance, is the lowest, the darkest density. So you got the minus 1,000 Hounsfield unit. He then measured water, and I call that 0. And then very dense structures like the bone ranges from 700 to 3,000 units. Notice that soft tissues kind of all have the same range of soft density. Blood has a higher density because of the iron content in the hemoglobins. It ranges from 45 to 65, depends on the amount of hemoglobin, and also depends if there's a hematoma, depends on the clotting. So if there's the clot developed, the clot retract and become hemoconcentrated, so the density goes up. So this is all for unenhanced structures. Okay, so let's see how we use this ability to measure this density or to classify this density in actual situations. This is a patient that was found in a dark alley, and they figure out that he probably was beaten up, so he got an aggravated assault. He was unconscious, so there's not a lot of history. Don't really know when that happened. So we did a CT scan anyway. This is a sagittal reconstruction, and you see there's the laceration in the spleen. And also we see some fluid down here between the bladder and the rectum. Okay? So obviously we're concerned for blood, but it could be other fluid, could be ascites, something like that. This is a actual image of this area, and here you see all the splenic lacerations, and there's a fluid around the spleen. And notice that the density of the fluid is not one homogeneous density. There's several different density, higher density here, lower density there. And we measure this by Hounsfield unit. We got 25.5 Hounsfield unit. And so this is certainly higher than transudate. Transudate or ascites should be like water. And this with the trauma, I would say this must be blood. So this patient has hemoperitoneum, but the density is below 35, so he probably is a little anemic. That's the reason for this lower density. Now we got to figure this out. So here we have a mixed density. We measure the density here. Actually, we got a pretty high number, 59, next to a low density number. So figure out that this must be a hemorrhage, and there's clotted, and the clot retraction caused some serous fluid here and some clotted blood there with a high density. So from there we can tell. Now it takes about 12 to 24 hours for a blood in the peritoneum and the peritoneal cavity to clot. So figure out from this that this is not an acute injury, but a subacute injury. So it happened at least 12 to 24 hours before that. So just by simply looking at the density, we kind of know a little bit more about this patient. So another example, this is the patient with lung carcinoma. And in metastatic workup, we look at the abdomen. Abdomen looks clean, except for there was a mass here. And this is a mass above the kidney, so this is an adrenal mass. Now, adrenal nodules are very commonly seen as a benign lesion. It's an adenoma. And on CT, actually, we can make this diagnosis because a lot of these adenomas have fat in it. So even though they're soft tissue with the presence of fat, the density decreases. And generally, if the density is 10 Hounsfield unit or less, then we consider this a lipid-rich adenoma. Okay. Now, this patient already have contrast, so we can't, so that 10 Hounsfield unit is for non-enhanced exam. So this patient was already given IV contrast, so we have to wait. 3 days later, we got the patient back, and there's the nodule now, a non-enhanced. We measure the density, and we got -5 Hounsfield unit. So now we can say this is a lipid-rich adenoma, and if there was a single lung mass in the lung, then this patient would be a good candidate for resection. If this was end up being metastasis, of course, it becomes a stage 4 disease, and a surgery would not be useful. Another patient with adrenal nodule. So this was an incidental, a patient with abdominal pain, and we scanned, we found this nodule. Okay, this was also done with contrast. So do we not get this patient back again in 3 days? Unfortunately, this was done with one of the scanner that we have using dual energy. So with dual energy, you can actually reconstruct the image subtracting all the iodine from the study. So like you virtually having a non-enhanced study. So we did that. So this is basically the virtual unenhanced exam, reconstructed, and there's the nodule. And we measure the nodule, we get 9 hospital unit. So this patient does not need to be a workup or follow-up. This is a benign adrenal nodule. Okay. One more example of the use of this density. Dr. Pickard was a professor in Milwaukee University, and he was very interested in osteoporosis. So he collected about 20,000 CT scans for whatever reason and for various ages, and developed a normogram for this. And it was published in Radiology 2019. And this was the normogram of bone density of L1, first lobar vertebral body. And notice that by age 30, bone density started to decrease. So don't think that osteoporosis is just disease of the old. When you reach age 30, normally the bone minerals start to decrease. So this is my message to the mahasiswas and mahasiswi, that if you're age 30, then you better keep exercising and watch your diet. Make sure you get enough calcium and vitamin D, because your bone density will decrease, but it's a normal thing. So this is how we use it. This was a patient with a big abdominal, with pelvic mass, turned out to be cystadenoma. But in doing that, we start seeing this line, this sclerotic lines here in the vertebral body. We know that when we lose mineral, it starts at the end plate and then works its way to the center. So this sclerotic line here is actually the remaining normal bone. So then we get the L1 vertebral body, measure the average density, and we got 110 Huntsville unit. So then we take out the charts of Dr. Pickard. So this patient is 57. So the lowest that we allow for the normal would be like around 128. So this patient is below that one standard deviation. So we call this a demineralized lumbar spine. And we then recommend a bone density or DEXA to see whether this patient is osteopenic or already osteoporotic. Okay, next topic is contrast enhancement. So in a lot of studies, a lot of CTs, we give IV contrast intravenously. That is iodine based, and iodine have a high density. So with that, we can actually enhance this iodine goes to all organs and vessels. So the parenchyma become denser, parenchyma enhance. And so this is useful to evaluate organ perfusion. And also active hemorrhage. When we see this contrast outside a vessel, that means that there's a bleeding, there's a vessel injury, and the blood, the contrast leaks out the vessel. So this is very important or useful in trauma. And we visualize the vessels. Already show you some examples for the artery, and I'm going to show you how we use this ability to visualize the veins and make diagnosis out of it. So we start with parenchymal enhancement. This was a patient that came with rule-out kidney stone, flank pain and hematuria, no stone seen, no hard nephrosis, we call it negative. 3 days later, 3 months later, patient came back from another reason, get a CT, this time with contrast. It enhances the kidney, but now we can see the mass. And if you go back here, I would not be able to call it a mass. Okay, I mentioned that it's a little heterogeneous. So cyst is very common, but it should not be heterogeneous. We actually measured the density. We got an average of 75 Huntsville unit. We went back to the prior study, and I didn't have the number here, but it's like around 30 or 40 Huntsville unit, just like a soft tissue. So this lesion is enhancing, meaning it's solid. Okay, so this is enhancing solid renal mass. It does not enhance exactly like the renal cell carcinoma, using the much more vascular, almost close to the kidney, but nevertheless, it's a solid mass. So we need to get tissue diagnosis. Okay, at the time, the selection is not to biopsy, just to go ahead and go. The patient actually has an MRI. The MRI wasn't really sure maybe an oncocytoma, maybe a low vascular renal cell carcinoma. So the patient went to surgery, and luckily it ended up being an oncocytoma. So oncocytoma is a neoplasm, generally not malignant, even though it could be precancerous, and in some small subset patient that actually there's some malignant element. So nephrectomy was the way to go anyway. Organ perfusion. So this patient came in with heart failure, congestive heart failure. You can see all this edema and the subQ, see the large perfusion with a compression atelectasis. And then we saw the what we call a wedge-shaped filling defect here. Okay, and because the rest of the spleen is perfused, we call it a wedge-shaped perfusion defect. Now, anything that has to do with perfusion have this wedge shape. Okay. So this is, we call it an infarct. And on this one here, you can also see some other infarcts in the spleen, also some in the kidney. Okay, so this patient has throws some emboli and it goes to all different organs causing infarct. And because he actually default have the bacterial endocarditis, there's a concern that this is actually a septic emboli. So this patient needs to be watched closely, make sure that's like this one does not become a splenic abscess. Right. Active hemorrhage trauma. This is a patient with a motor vehicle accident. So it's an accident. And here we have the aorta, very dense, but it's a lot of contrast also outside in the retroperitoneum, outside the aorta. So this has the same density. So if there's blood in here, this all must be blood outside there as well. Okay, so there's some retroperitoneal hemorrhage. And because this is the same density as the aorta, this is a arterial bleed. The venous bleeds and oozing from the capillaries are generally slow enough so we don't see the contrast exacerbation, but bleeding from an artery is brisk enough that we can see contrast as a high density like this. Also notice that the kidney is not perfused completely. So the diagnosis is active hemorrhage, mean arterial hemorrhage, with renal devascularization. Part of this one is not vascularized. And on this coronary constriction, the further wider problem is, this is the renal artery and it stopped right there. Okay, so this is transection of the renal artery causing the bleed and also caused the infarction, so to speak, of this kidney. Vessel visualization, like I mentioned, we're going to talk about veins this time. So this was a patient with hepatitis C infection and developed cirrhosis. This is a coronal image of the upper abdomen. We did recognize some nodules here. Not really sure. That could be maybe reactive lymphadenopathy. Esophagus may be a little bit thick. Not really sure what to make out of that. Once we give contrast, all these nodules here lights up. So these are tortuous vessels, and they're big enough to be varices. Okay, so and knowing that this patient has cirrhosis, we call this varices. So this is left gastric varices, gastric varices, and also a lot of varices in the esophagus, because you know that the lower esophagus drain into this left gastric. So the left gastric become varicose. These also become varices, and that's bad because it's one of these varices rupture, you know, that causes this massive hemorrhage. Another case that sort of depends on imaging of the veins. This is a patient, 47, G4, not pregnant, with a chronic left lower quadrant pain and low back pain, become worse during periods, during menstruation. Diagnosis, okay? So if you're not familiar with this syndrome, this is pelvic congestion syndrome. So what is pelvic congestion syndrome? It's chronic pelvic pain due to congested pelvic varices, which is a result of reflux from the left renal vein. And this is not a new entity. People start describing it way back in 1857. And the first radiologic description was also very long time ago. But the diagnosis is often overlooked. And in a minute, you know why that is. It's not rare. So a lot of women with chronic pelvic pain, and there's a lot of them out there, 30% of them are due to pelvic congestion syndrome. Okay. And it's disease of the patients, people that are in the childbearing age, especially when they have multiple pregnancies and it's not reported in postmenopausal. Okay. Symptoms. So we got this chronic pain, it's vague, exacerbated during periods, left-sided, dysmenorrhea. Dyspareunia is also a common complaint. Pain may be low back pain or the lower abdomen. And sometimes they are not even referred to the pelvic organs. Like people may complain of rectal discomfort or bladder irritation. And this is the reason why often the diagnosis is missed. Basically come with rectal discomfort or bladder irritation or even low back pain. Or if they come with dysmenorrhea and dyspareunia and come to complain to the physician, they say, well, that's normal. Dysmenorrhea, that's why they call it the cramps, because it's supposed to hurt. So this entity is often ignored either by the patient or by the referring physician, which is kind of unfortunate. Okay. Clinical, there's not a lot of clinical findings. Varices, maybe see it in the vagina and the vulva and the upper thighs, and a pelvic exam, there may be some tenderness on the left. So very little clinical signs. So how does this happen? The renal vein has a very high, renal kidney have a very high flow. So there's a lot of pressure in the renal vein on the return. And this pressure is transferred into the left ovarian vein, which is, drain into the left of renal vein. And this reflux is prevented by valves. So that doesn't happen. During pregnancy, normally the veins will dilate. And if this continue, it become chronic, the valve become incompetent. They no longer meet. And therefore now we have reflux. And if we give contrast, that contrast will reflux in the ovarian vein. So we get this dense varicose left ovarian vein. And eventually also it reaches the pelvis. Now we get dense left pelvic varices. So a little bit about the ovarian vein. The normal ovarian vein is very small, maybe around 3-4 millimeter. And there's not a lot of blood from the ovaries, so the density is less compared to the IVC. During pregnancy, normally the ovarian veins will dilate. And hopefully it remains dilated after pregnancy, and especially after multiple pregnancies, it's normal to have veins this large. But as long as there's no reflux, the density will still be pretty low, less or same as the IVC. The renal vein, like I mentioned, has a high flow. So this is an example of a very dense renal vein, which is normal. And if this ovarian vein is incompetent, then the same contrast will go into the renal vein. So this is a dilated left ovarian vein in pelvic congestion. Okay, so then if we compare it to the IVC, you can see that it's much denser, and the reason is because of all this contrast in the vein, reflux into the ovarian vein makes it to cause it to dilate and eventually become varices, like you see here, very tortuous. And then if it reaches the pelvis, it becomes dense left pelvic varices. Okay. So the IVC, a dilated left ovarian vein, varicose, very dense, and find left dense, left pelvic varices, then we say this is a patient with pelvic congestion syndrome. Now, pelvic congestion. Now, the syndrome is required the pain. So when we see this finding and the patient have the classical symptoms, then we say this is compatible with pelvic congestion syndrome. Now, pelvic varices is very common during and after pregnancy, usually it's on the right side, and the density is not more than the vein, systemic vein. So here we compare it to the external iliac vein. Okay, so we compare with the pelvic congestion here, see these varices is much denser than the external iliac vein. And usually from anatomic reason, it's more common on the right. Pelvic congestion syndrome, pelvic congestion start on the left. Now, there's a lot of communication between the left and the right vein. So eventually this dense contrast also causes varices on the right. So it's bilateral pelvic varices. Sometimes you have crossing also of this contrast to the uterus. So these arcuate veins that bring this contrast from the left to the right. So patient have bilateral dense pelvic varices. So the keyword is dense. If you have pelvic varices that's dense, it's due to pelvic congestion. All right, so that's Congestion enhancement. We'll talk about how we use that in the dense veins to make certain diagnosis. Next topic is the expected. Okay. So what I mean by that is that a straightforward diagnosis of an expected condition. Because if a patient have a right lower quadrant pain and tenderness with fever, we say patient likely have acute appendicitis. Okay. Now, before you call the surgeon, you better make sure that it's acute appendicitis. So CT is to confirm the diagnosis. Let me give you a scenario. Patient with the Crohn's disease, having an inflammation of the distal ileum and the cecum, will come with the same symptoms: fever, pain, tenderness in the right lower quadrant, maybe even some increase in the white counts. And if you call the surgeon to operate on that, it will be disaster. Number one, he doesn't find the appendicitis. The patient actually does not need surgery. And these patients are typically healed very slowly. So this patient is going to have like a draining sinus for months. Okay, so you're going to have a surgeon who's very mad. Okay. So the diagnosis need to be confirmed. And often there may be some other additional finding that's important. See, that patient with acute appendicitis have developed an abscess. Surgeon doesn't like to operate with an abscess. Okay, so this patient needs to be cooled down after with antibiotics, maybe 3 months down the line when everything is cold, then go and do the appendectomy. Okay, so we just have exactly a case like this. This patient with right lower quadrant rollout appendicitis. So the question is that indeed appendicitis or other entities, other pathology that is not appendicitis and may not need surgery. So the findings on acute appendicitis, so we'll talk briefly about how we get acute appendicitis from an obstruction. So the continuous mucus secretion causes the distension of the appendix that will create pain. Remember, this is not appendicitis yet, it's just a distended appendix, and we see that on a CT. The continuous distension causes ischemia, bacterial infection. Now you get acute appendicitis, and then we get an inflamed appendix, which causes edema. We've got wall thickening. You get hyperemia, and also the fat around the appendix become inflamed. So all this here in yellow is things that we can see with CT. Okay. Now distension is the earliest and the most consistent sign of acute appendicitis. What it means that if you have no distended appendix, you cannot have acute appendicitis because we start with an appendix obstruction. So you can make a statement that a normal size appendix excludes acute appendicitis. If your patient come in with whatever clinical said, this patient have appendicitis, you do a CT and the appendix is normal, you can make the statement, there's no appendicitis. Okay, so what's the normal appendix? Here, the wall, we measure the wall to 3 millimeter. And if the appendix is collapsed, then we have 2 times 3 millimeters, so we got 6 millimeter. So here's an appendix, I magnify that. So this is the appendix here. Now this appendix is not collapsed. So we cannot use the 6 millimeter, but the wall is very thin, maybe less than 2 millimeter. So this is a normal appendix. The classical appendicitis. So here also we have appendix not collapsed, that often with patient have appendicitis, this is filled with pus, so it's not collapsed. So, but we measure the wall is 4 millimeter, and there's some inflammation around it. So we have some periappendiceal inflammation, we have a thick inflamed wall, acute appendicitis. So we cannot always rely on this wall. See, here we have a patient that has an extremely distended appendix to 1.5 cm. The wall is stretched to the point that it becomes very thin. So even though its edematous is about like less than 2 millimeter, but there's some inflammation around it. And there's some other signs that we can use. For instance, we can look for hyperemia. So this is another case of appendicitis. Not really large, the wall may be about upper normal, but we measure the density of the wall. This is with contrast, and due to hyperemia, the wall become 103 Hounsfield unit, and then we look at the other rest of the bowel, only about half of that. So this is a hypervascular, hyperemic appendix, and therefore we call this appendicitis. And there's some few other signs that we can use that for the time constraint. We're not going to discuss that. So not a straightforward diagnosis. Now we have an older patient, left lower quadrant pain and fever, some septic, some tenderness. So we think of acute diverticulitis. At least in the United States, a lot of meat eaters, especially in the South. So a lot of people get diverticuli, especially the men. They like their steaks. So we have a case like that and we say this is likely acute diverticulitis. Here you see the sigmoid, very edematous, and some surrounding inflammation. So this is a diverticulitis. So we say likely diverticulitis because this is basically colitis. Could be any other colitis, could be bacterial or viral colitis, could be inflammatory bowel disease, but there are several ways to several criteria to differentiate the two. This again for time constraint, and we will not be able to discuss this. What is also important is to see if there's any complication from this. So here's a patient with the sigmoid diverticulitis. Is sort of the end of the sigmoid. See a lot of inflammation here. And there's a little fluid collection next to it, kind of around it. And we follow that is actually a pelvic abscess. So if the inflammation or the diverticulum ruptured, become inflammation, become infection around the colon, and that produce some fluid, and the fluid become infected to become an abscess. Okay. And in fact, the most common cause of a pelvic abscess in the male is acute diverticulitis. In the female, we have a lot of pelvic inflammatory disease that may also be the cause. Okay. The same patient, we saw this soft tissue extension underneath the posterior to the symphysis. Wonder what that is. So on a coronal reconstruction, you can see this is actually an inflammation next to the sigmoid, and it looked like to extend to the bladder. The bladder react with causing some thickening here. There's some hyperemia, it's a little air bubble there. So that means there's a sinus tract from the sigmoid to the bladder, and some more images of the bladder will confirm the concern that this has a fistula. So we have air on the bladder. So this is a colovesicular fistula. And not too common, but especially in chronic diverticulitis, often it continues to become a colovesicular fistula. Another not so straightforward diagnosis. This is a young patient this time, has right lower quadrant pain and fever, worry about acute appendicitis, obviously. And if you look carefully, there's the appendix. Normal, very thin wall, no surrounding inflammation. So the patient does not have acute appendicitis. Looking at the rest of the abdomen, we see a lot of inflammation in the right lower quadrant. So this is the cause of the symptoms. And on the sagittal reconstruction, we see clearly that this actually is attached to the sigmoid, to the cecum. So this is this part here. In fact, the patient have another diverticulum here. So this is right-sided acute diverticulitis. Okay. So the diverticulum that we usually see in older people is usually on the left side on the sigmoid, because that's where the feces become solid and the most pressure from constipation is there. Diverticulum on the right side is congenital. Okay, and statistics will say that this congenital tics, of course, can occur at any age, and these tics have a higher incidence of diverticulitis and perforation. So this is an example of right-sided acute diverticulitis, and this is another reason why you want to just call appendicitis from clinical symptoms without having a CT. Another common situation, patient with flank pain, hematuria, you worry about kidney stones. Patient does not have stone in the kidney, but have hydronephrosis. Okay, so this is fluid-filled renal pelvis that's distended. If you have the renal pelvis that's collapsed. So while the patient have hydronephrosis with the symptoms, of course, be worried about a stone that's obstructing. So we follow this, and there is the dilated ureter, hydroureter. We follow that ureter down to the pelvis, and there's a stone in the uretero-physical junction. Or is it? Okay, so look at this here. the stone seems to be a little bit inside what we think is the lumen of the, so does the patient pass the stone already, or is it still stuck at the urophageal junction? We also know that a lot of time this urophageal junction it become pushed inside because there's a lot of inflammation in this area. This wall become edematous, become thickened, and the UVJ, instead of being here, is not there. Okay, so in order to know where the stone is there exactly, we put the patient prone, and we figure out that the stone is still in the UVJ. It does not drop down. Okay, and this is important because the patient continue to be obstructed. Sometimes these stones does not pass for 2-3 days, and then the urologists have to come in, have to take this out endoscopically, because not only the symptoms continue, but this continuing obstruction sometimes may lead to a superimposed infection. Another case, now the pain is on the left. We also again have some hydronephrosis. We have the hydroureter, and we find a stone in the UVJ as well. Again, it looked like maybe a little bit beyond where we expect the bladder to be, not really sure. Question mark UVJ, we put the patient prone and the stone dropped. So now we can say nothing to worry, the stone has passed. Okay, one more common condition, a straightforward diagnosis, patient with diffuse abdominal pain, abdominal distended, non-tender. Concern is so anything worried about in the abdomen, first take an abdominal film, and we see this dilated bowel loops. Okay, now remember that X-ray only see gas-filled bowel loops, so there may be other bowel loops here that's also dilated, filled with fluid, that is not visible on radiograph. So the question is, the patient so we know the bowel is dilated, is it due to an ileus or the patient of obstruction? Patient went to CT, and we find a lot of these bowel loops. These are the loops that are not seen on a radiograph because they're fluid filled. But we also find this corner here, a lot of loops that collapse. So that means somewhere in between these loops and that loops, there is an obstruction. Okay. Now, we don't always find the point of obstruction, which is called the transition point, but in this case, we did. So this diagnosis of small bowel obstruction can be made simply from this one image. We have a combination of dilated bowel loops and collapsed loops. That means in between there is a transition point. And here actually we find a transition point, which is here. You can see the obvious change in caliper. Since most of the obstruction is due to adhesions, and adhesions not visible on CT, so that's why we do not see the cause of the obstruction. Tumor and the small bowel is very rare, so most of the time we do not see the cause of the obstruction. There's another sign here for obstruction, which we call the small bowel feces sign, because the content of the bowel is stuck here. The content become rotten and produce bowel gas, just like what happened in the colon. Now, once we make the diagnosis, we look farther. So here we have loops that are edematous. Okay, so the constant pressure, constant distension, called ischemia of the bowel. So this is ischemia, small bowel ischemia, and this continued to become small bowel necrosis. And that, of course, is not good because the bowel can perforate and cause peritonitis. So this become more an urgent surgery. So those are like an expected diagnosis, and where CT has some helpful to confirm that and to add some additional information. Now we come to the unexpected diagnosis. So we call this in radiology, we call incidentalomas, findings that we not expect to find. So first case here is the patient with, again, in a motor vehicle accident. The abdomen was okay, no trauma, but we saw this thickening of the breast. Okay, so we call the surgeon, the ER, the trauma surgeon, say, is there any pain? The patient have any trauma to the chest? Because the wall looks a little thick, maybe it's a contusion. So, well, I say, no, the patient doesn't really have any symptoms. I do notice that there is some redness in the breast, but the patient has been there for a while and it's not tender. But he said, it looks a little funny. There's some little, almost like there's some little bits in there, almost like the skin of an orange. And then we remember that this is spot orange, which is a skin thickening inflammation that you see from an underlying carcinoma. Now, finally, this patient has also have a lumbar spine, and from the raw data of the lumbar spine, we reconstruct the chest. So this is chest of this patient, and there is the mass. So this is a Paget's disease, which is basically a subareolar carcinoma, ductal carcinoma. And also the patient have another mass here that is adenopathy for the lateral thoracic. Okay, so from this skin thickening, this was an incidental finding. We got the diagnosis of that, but certainly now change the management of the patient. Okay. Some may find also incidental things in other areas. This patient had chronic epigastric pain, so the pain was in the upper abdomen. But by the time we get to the pelvis, we saw this mass here, very vascular with a necrotic center. So we worried about some kind of malignancy. It turned out to be this was a papillary carcinoma for remaining right ovary. This patient did not have a hysterectomy at a younger age, and they left the right ovary in there, and they develop a carcinoma. And we can also stage it because this is sigmoid here. Is irregular thickened, so it's likely infiltrated. So in the TNM system, this is a T2B states of a local tumor. This was a patient with lung carcinoma. So we've been following this patient for a while, and we lost a follow-up. The patient just disappeared. So he came back 3 years later, I think moved back to Dallas, and he came back to the hospital, said, well, let's pick up the care, and we scan him again, see what happened to the lung carcinoma. The lung carcinoma was okay, did not return. There was no metastasis anywhere, but we saw this. So the esophagus is distended and is very dense. And this is contrast on the stomach that reflux in the esophagus. The oral contrast, which is also some kind of iodinic contrast, is very dense as well, but it's very dilute. It's almost like it's a 2% contrast. So it's almost like water, and it should clear the esophagus just a few minutes after the patient drink. So any contrast that's in the esophagus is a reflux on the stomach. Okay? And the patient had said, well, you have a lot of problem with reflux for a while. So this is the patient esophagus 3 years ago. Was much smaller, and there was no reflux. So this patient had GI reflux, and because it's been there for a while, we refer the patient to GI. Gastroenterologist did endoscopy and found Varices. So this is one complication of prolonged gastric reflux, changes in the mucosa. It's called Barrett changes, and the Barrett is actually like a precancerous condition. So on the biopsy, actually was a high-grade dysplasia. So this patient definitely needs to be followed, or maybe even get like an ablation of the mucosa, because this is a precancerous condition. Okay, so finally, CT guided procedures. So CT has the ability with cross-sectional anatomy to know exactly where the organs are, where the pathology is, where structures to be avoided are. So this example, this is a patient that came with some back pain, chronic back pain, and a CT, we found a lot of these masses along the para-aortic area. So this is lymphadenopathy. It's likely some sort of infectious process. You can see a lot of inflammation around it, but what it is kind of hard to tell. Okay, so biopsy is needed, but requested coming from the front. We have a lot of this mesenteric vessel to deal with. The bowels may be in front of it. So the best approach is coming actually from the back. Okay, I have to scan between, I have to go between the spine and the kidney, but I have to go posteriorly. So we put the patient prone. There's some localized needles here, and we decided on this track. So it's next to the spine, it's away from the kidney. There's the aorta, that's the IVC. So this is a safe bet. So with CT guidance, we put the trocar. This is an 18 gauge hollow needle, about halfway, so we don't go too far. Not this is probably already too far. Make sure that's not touch the kidney if we got a wrong angle. But luckily the angle was okay, and through that we put the biopsy needle all the way to the surface of the mass, and then we use a device called the biopsy gun, and that will throw the needle maybe 1 or 2 centimeters. We can adjust that and capture the tissue. Okay. So that's the CT guided biopsy. This was that patient with a pelvic abscess. A lot of the abscesses, or most of the abscesses nowadays, are drained percutaneously. Surgery is not only something that surgeons don't like to do, but also the use of the drain with a Penrose drain, which is kind of passive drainage. We put a catheter in and hook it up to a suction machine and get rid of this pus very quickly. So coming from anteriorly, we have the bladder, we have the vessel. So this decided to go from the back, and we choose the right side here because the rectum is still deviated to the left. So this is a farther distance from the rectum. We want to be close to the sacrum because the major vessels are here, and also the sciatic nerve is here, right in that area. We don't see the sciatic nerve, but we know where it is. So we want to stay away close to the so they put the patient on the side because the patient have trouble lying on the stomach. And this is the trocar needle again. And through that, we're happy with the passage. Then we put a guide wire through it, all the way into the cavity. And then we establish that the guide was inside here. Then we slip the catheter over it. So in closing, CT is widely available. I think there's many places have CTs, even in the emergency room. Is very useful and a robust diagnostic modality that hopefully I've shown you so far, and to solve problems in the abdomen. Just remember that this is a lot of radiation. So consider alternatives like ultrasound and MRI and pediatric and a patient that are pregnant. And with that, that should be the end of today. Thank you very much for your interest and for listening. And if there's any question, I'd be glad to answer that.
Terima kasih pada Prof. Antoni Setiawan yang telah memberikan materi yang sangat menarik dan sangat informatif. Ya. Sekarang memasuki sesi tanya jawab. Ya. Persilakan pada partisipan untuk menyajikan pertanyaan, bisa lewat chat box atau bisa langsung resend. Ya. Ya. Mungkin sambil nunggu pertanyaan dari audien, Prof. Kita tahu pada CT scan abdomen mau nggak mau menggunakan kontras, Prof. Bagaimana untuk yang ada problem di renal function, Prof? Jadi misalnya graded.
Ya, untuk renal function itu memang problem. Sebab itu iodine contrast itu nephrotoxic. Jadi renal functionnya bisa tambah jelek. Biasanya dapat ATN ya, acute tubular necrosis. Di literature ada macam-macam cara untuk menangani ini. Ada yang memakai sodium bicarbonate, tapi yang ternyata yang paling berguna adalah hydration. Jadi typically, tapi melihat renal functionnya, kalau GFR-nya itu di atas 60, kita not worry about the kidney. Kalau GFR-nya itu between 50, I mean, let's see, it's between 60, yeah, between 50 and 60. Okay, 60 and 50 itu kita hydrate the patient. Jadi sebelum dikasih AV contrast, kita kasih saline 250 cc. Itu untuk hydrate the patient. Kalau di renal function lebih jelek, jadi antara 40 sampai 50, kita hydrate 2 kali, jadi sebelum dan sesudahnya. Kalau GFR-nya di bawah 40, kita bilang ini terlalu jelek, kita tidak bisa kasih. Jadi either kita non-contrast, jadi kalau misalnya patient sama lymphoma gitu, mungkin kita hanya cari lymphadenopathy, kita terus. Kalau enggak, kita cancel dan kita bilang lebih baik patient dilakukan MRI.
Any question? Ini ada raise hand dari Dr. Arvin. Silakan, Dr. Arvin.
Selamat pagi. Should I ask in English or in Indonesia, Dokter?
Indonesia enggak apa-apa.
Ya, Prof. Terima kasih, Prof. Saya seorang GI surgeon, jadi saya merasakan sekali bahwa imaging abdominal itu indispensable ya kira-kira di dalam semua planning dari operasi. Nah, ada dua pertanyaan yang sebenarnya menggelitik karena kami sebenarnya sudah lazim untuk berdiskusi dengan radiologi sebelum operasi. Cuman yang menggelitik satu adalah apakah memberikan informasi klinis, ya artinya dugaan-dugaan klinis, pemeriksaan-pemeriksaan klinis suatu disease kepada seorang radiolog sebelum dia membaca image-nya itu membantu atau justru malah menyebabkan masalah, artinya menyempitkan DD yang kemudian bisa dilihat dari radiologi, dari imaging. Karena memang kan kita punya, ya dia mungkin hanya terfokus pada daerah itu dan kehilangan kehilangan perspektif pada daerah yang lain.
Iya,
Itu
betul.
yang pertama.
Ya, itu memang betul. Kadang-kadang bisa bias gitu ya. Tapi sebetulnya, Anda tahu, ya setiap radiologis itu they have a different approach ya. Kalau saya itu klinik ya, di keterangan klinis itu sebetulnya membantu sekali. Tapi sebelumnya saya membaca dengan bantuan klinis itu, saya baca biasanya 2 kali. Jadi pertama saya baca, saya menghiraukan semua informasi klinis, saya baca just as a case de novo, tanpa pengetahuan ya. Tentunya di informasi ada umurnya berapa, ini race-nya apa, seksualnya apa gitu. Lalu saya baca itu, lalu setelah itu saya baca kembali lagi dengan clinical information itu. Yeah, that's actually the way to read any imaging. Sebab memang kita tahu kadang-kadang kita jadi bias ya, karena sudah misalnya appendicitis ya pikirannya ke appendicitis itu kadang-kadang bahaya, itu kadang-kadang kita bisa luput. Ya kalau contohnya kalau pasien datang dengan trauma itu kita hanya melihat organnya ada trauma tidak, ada perdarahan, nanti ada cancer di kolon, keluputan itu. Dan itu bukan hanya teori, itu ada kejadian benar itu.
Iya.
Jadi otaknya itu kita sudah ke arah seperti you bilang, kita arahnya ke kanan, ada problem di kiri nggak kelihatan.
Baik. Yang kedua, Prof, terima kasih, Prof. Itu artinya ya sama, kami juga berpikir demikian. Yang kedua mengenai cancer surgery, cancer imaging, Prof. Jadi barusan ya mungkin ini kita punya pancreatic head cancer dan based on radiology ya, karena memang pancreatic head cancer itu sulit untuk mendapatkan pemeriksaan lain ya. Itu tidak ada invasi pada vascular main vascular. Jadi kita kan harus melihat apakah superior mesenteric artery-nya itu ditutupi oleh atau diinfiltrasi oleh kanker atau tidak. Nah, dari image itu hasilnya tidak ada, Prof. Nah, oleh karena itu, maka planning operatifnya adalah Whipple operation. Tapi ternyata durante op itu kita mendapatkan infiltration. Nah, dalam hal seperti ini, Prof, ini kan problemnya adalah bahwa seringkali bukan radiologis ya, maksudnya patient itu juga ekspektasinya berbeda pada waktu kita melakukan planning operasi dan inform consent ketimbang temuan operatifnya. Nah, jadi kira-kira apakah ada cara untuk mengurangi kemungkinan bias ya kira-kira dari perbedaan antara clinical findings dengan radiological findings, Prof? Apakah itu mungkin Prof punya masukan?
Iya, kita sebetulnya aktif sekali di bidang pancreatic cancer, and sebetulnya itu ada reporting itu sekarang kita banyak menggunakan reporting system supaya standardized. Ada template-nya gitu. And kalau yang anybody ready to study itu mesti mengikuti template itu. And one of the template requirement itu mereka mesti bilang vascular involvement. The SMA, celiac axis, and in fact itu one of the branch of the first branch of the jejunal artery itu juga mesti. Jadi memangnya kalau kita hanya kasih kontras seperti kita melakukan kontras untuk cari abses, appendicitis, itu kadang-kadang arterinya itu enggak, enhancementnya kurang. Jadi kita punya protokol spesial untuk pancreatic cancer. Dan dalam protokol ini juga kita tahu bahwa pankreas itu vascularisasinya tidak seperti liver atau kidney. Vascularisasi not that good. Jadi kita ada juga itu kan CT itu karena cepat sekali kita bisa mengambil imaging dalam fase-fase tertentu. Jadi ada fase untuk pankreas, ada fase untuk arteri. Jadi kalau kita scanningnya early sekali, within 15-20 seconds, itu arterinya atau enhance-nya bagus sekali. Kalau little bit delayed, itu pankreasnya enhance. Jadi untuk melihat mesh-nya sendiri di pankreas, itu kita mesti lihat di pancreatic phase. Kalau mau melihat arteri, ya SMA, the celiac axis, everything, kita lihat early. Gitu. Jadi kalau dilakukan dengan pancreatic protocol, itu mestinya tidak ada problem itu. Mestinya bisa. Tapi kalau kontrasnya hanya biasanya kalau buat abscess, buat appendicitis kita scan kira-kira 60 second after the injection. Itu sudah terlalu lat buat arteri. Jadi mungkin itu sebabnya kadang-kadang tidak bisa tahu ini infiltrasi apa enggak. Tapi kalau scan-nya early, around 15-25 second, arteries itu enhance-nya bagus sekali, mestinya bisa tahu.
Jadi klinisi harus meminta pancreatic protocol ya, Prof?
Ya, jadi specify pancreatic protocol. Ini radiologist mesti tahu. Ini sebab kalau kita itu publish di mana-mana di major journal, and radiologistnya mesti mengerti. Dr. Damadi bisa can tell you about it.
Thank you, Prof. Thank you very much.
You're welcome.
Baiklah, terima kasih Dr. Arvin. Pertanyaan berikutnya, Prof, di chat box from Dr. Dewa Ayu, Prof.
Okay.
In what cases is the better to do?
Mana kau nggak bisa lihat nih chat ini. There is Stanley. I'd like to ask, how does eating red meat cause diverticulitis? Oke. Rupanya ini Stanley suka steak juga ya. Ya, ini itu meat, as you know, is fibernya kurang. Kalau kita makan banyak vegetables, makan sayur-sayur itu fibernya banyak. Jadi kalau fibernya kurang, itu orangnya itu jadi constipated, banyak constipation lah. Constipation itu kalau feces di sikum, di ascending colon itu semua masih dalam bentuk liquid. Itu kalau dia pelan-pelan jalan di kolon, itu airnya diabsorb, jadi dehydrated, jadi keras. Jadi di sebelah kiri, di descending colon itu fecesnya solid. Itu kalau fibernya kurang, perjalanannya kurang, itu feces stuck di situ, jadi lebih keras, orang jadi constipated. Jadi karena itu diverticulum itu biasanya di sebelah kiri. Yang saya terangkan yang diverticulum sebelah kanan itu generally congenital. Jadi itu ceritanya kalau hubungannya daging sama diverticulosis, sama diverticulosis. Nah, diverticulosis nanti satu saat jadi inflame apa perforate jadi diverticulitis. Ada chat lagi tadi.
Ada raise hand, Prof, dari Prof Paul. Raise hand question. Silakan Prof Paul. Ada raise hand dari Prof Paul. Silakan Prof Paul.
Di chat juga atau di mana?
Di raise hand, Prof Paul.
Itu di chat dulu dah, ya Pak.
Ya.
Dr. Leona, Dr. Leona dulu. Tidak apa-apa.
Oke.
Ya, saya belakangan.
Oke, go ahead.
Dibaca aja in what cases.
Ya, ini
Leona Dewi, Dr. Leona Dewi.
Coba ini pertanyaannya adalah
In what cases, Bro?
dari Ivan Andi. Ya.
No. In what cases? In what cases
is it better to do the CT scan than MRI?
For what?
Yeah, for what? I think this...
Yeah, well, MRI itu is an entirely different modality. They basically have a very good tissue differentiation. So in some degree, like looking for liver masses, they are more sensitive. And mereka juga punya tissue differentiation tersendiri. Jadi misalnya mereka bisa diagnose papillary renal cell carcinoma based on the. Saya nggak MRI expert, jadi ya nggak itu tahu. But MRI itu lama sekali. Ya, sequence-nya banyak karena 1 jam for the whole process. And one of the advantage of CT sekarang itu is very fast. Jadi kalau misalnya kita bisa scan abdomen in 20 seconds, so from the diaphragm to the symphysis. So in emergency situation, then we go to CT. Kita ada MR juga in-house, tapi kita tidak gunakan buat emergency. So tapi pakai CT. So it's kind of hard to compare MR and CT because they both work with different principles. So I hope I answered that question. So there's another question here. Andy, is it needed to perform abdominal CT with contrast patient who had suspected renal rupture? Well, how do you get the diagnosis of renal rupture? Ya, sebab itu retroperitoneal hemorrhage. Jadi kalau kidney-nya rupture itu gini, kalau kidney ada injury, itu generally retroperitoneal bleed itu is more have a lesser morbidity than intraperitoneal. Kalau misalnya kita ada splenic injury, itu bleedingnya itu bisa tidak stop, sebab blood will go into the peritoneal cavity, and as you know, peritoneal cavity bisa contain 11 liter, jadi patientnya bisa exsanguinate just from a splenic rupture. Kalau injury-nya retroperitoneal itu contained. Jadi at the one point, hemorrhage is the hematoma is so large, it compressed the bleeder, so it's self-tamponate. Jadi generally kalau ada kidney injury itu kita lebih konservatif. Jadi kalau pasiennya menjadi shock, ya of course kita intervene di coil or something like that. Tapi kalau enggak ya kita just watch saja. What is important buat renal injury itu mau tahu apa juga ada urine leak. Jadi biasanya kalau ada kasih kontras, kalau ada renal injury kita tunggu, kita delay sampai kidney-nya excrete. Dan kalau ada kontras di luar kidney berarti ada urethral or pelvic injury. Dan kalau gitu kita mesti pasang stent. Sebab itu urine leak itu discontinuous and it's not gonna stop as long as there's a urine leak. Dan pertanyaan kedua, does demobilization of bodies can need to continue to XA? Ya, itu maksudnya itu di study itu from Dr. Pickard itu detect patient yang have a demineralized bone. And karena kita tidak bisa tahu ini stagingnya apa, ini osteopenia, osteoporosis, and what grade, itu rekomendasi untuk patients dan segala umur. Kalau misalnya umur 45 tahun and is below the 2 standard deviation according to the chart, dan kita tetap recommend bone scan untuk confirm dan juga untuk staging. Sebab itu nanti menentukan terapinya gimana. Dan juga untuk follow up. Kalau patientnya after treatment, does it work or doesn't work? We need the bone scan or bone density to do that. And then as a third question, mana yang harus dipercaya, serum creatinine atau GFR? Kalau kita pakai GFR, sebab you know that serum creatinine is not that reliable. A lot of factor is affecting that. And so GFR, GFR itu sebetulnya bisa dilakukan sama lab. So di hospital saya itu setiap kali dilakukan serum creatinine, otomatis mereka dihitung GFR-nya. Tapi sebetulnya ada formula juga. Kalau you Google calculation of GFR or something like that, itu banyak orang yang ada formula di website. Itu kita masukkan age of the patient. Kalau di Amerika juga race, ya. Jadi kalau African American itu lain sama kalau yang different population. nanti akhirnya dan serum kreatinnya dimasukkan, nanti GFR-nya keluar sendiri. So the GFR is more reliable than serum creatinine. And let's see if there's any. So I think there's ada chat lagi.
Sementara sudah, Prof. Mungkin langsung Prof Paul, silakan Prof. Pasien dari Prof Paul.
Ya, Prof Antoni, sorry.
Hai.
Kok bisa mendapat kasus yang sangat sulit ya, sangat langka mungkin ya, varices di daerah pelvic area. Dan
itu
special,
sebetulnya ya saya bilang itu is very common.
Oh, common
itu,
di Amerika ya, tapi di Indonesia saya tidak pernah selama ini mendapat itu.
Well, it's to be honest with you, itu sebelumnya ada artikel itu is often also missed by radiologists.
Oh ya.
Kadang-kadang saya lihat kasus-kasus yang lama itu terus di depannya nggak disebut sama sekali.
Boleh tanya, the surgeon yang ngirim atau the internist ya?
Yang apanya?
Yang men-refer ke radiologi siapa? Dari surgeon
itu yang
atau
saya
dari...
itu nggak ada berdasarkan reference. Itu apa namanya yang saya ambil kasus-kasus yang tunjukkan itu semua dari patient dari yang trauma. Jadi dia trauma, dapat CT, saya lihat itu saya sebut. Dan saya juga ada patient yang karena itu pain-nya itu enggak selalu, kadang pain-nya itu di low abdomen. Jadi patientnya datang low abdominal pain, di scan, itu diagnosisnya disebut, 3 bulan lagi datang lagi.
Oh ya.
Jadi itu, if you miss it, then you know you miss it.
So the main complaint is pain.
Is pain, tapi kadang-kadang pain itu agak membingungkan. Itu low back pain, jadi nanti X-ray dari back. Kadang-kadang problemnya di urine atau di rectum. And ini ya, that's the thing. Ini sindrom ini sudah lama sekali dan terapinya itu dulu ligasi. Itu kalau keluarnya dysmenorrhea, si patientnya bilang, wah, gak mau surgery besar gini, dysmenorrhea gitu. Tapi sekarang itu kita bisa embolize. Jadi embolize itu is an outpatient procedure, masuk pagi, pulangnya siang, and about half of the time begitu di embolize simptomnya hilang. 25% of them have some relief of the symptoms. The other 25% tetap sakit. Jadi it's another reason for the chronic pain. But I think 50% resolved or 25% partial resolution. I think that's a pretty good result.
Okay. What is the main symptoms? It's only pain or other symptoms? Discomfort of the abdominal?
It's pain. It's the main thing is pain, but the pain, like I said, can be very confusing. Dysmenorrhea, dyspareunia, low back pain. Painnya bisa rectal irritation, bisa bladder irritation. So it's often confusing. The diagnosis is missed or ignored. The patient ignore it, say, man, it's just low back pain, or they go to their family doctor and they say, well, that's supposed to hurt when you have periods.
Okay, thank you very much for Tony. Okay.
Silahkan partisipan, masih ada pertanyaan. Mungkin sambil nunggu, Prof. Saya tanya, kalau ini ada pasien USG, didapatkan mesh solid di para-aorta. Di sisi lain ternyata grafik trimester pertama, Prof. Dimintakan CT scan abdomen. Biasanya solusinya gimana, Prof?
Jadi orangnya pregnant. Itu ya kalau keadaan gitu di MRI. Jadi MRI the only time, jadi hanya satu condition di mana kita lakukan CT on pregnant patient itu kalau trauma. Sebab MRI terlalu lama, ini kita harus ambil cepat-cepat bikin diagnosis. Kita lakukan CT, tapi sebelumnya CT itu kita consult patient dulu, kita bilang ini ada radiation. So kalau first trimester, kalau itu first trimester itu yang bahaya. Tapi kalau second, third trimester itu the effect of the baby is minimal. Kalau first trimester kita consult sama patientnya. You need the CT, ini life threatening. Kalau ada splenic rupture bisa mati, tapi you're pregnant, and ada kemungkinan, tidak pasti, tapi ada kemungkinan baby-nya bisa affected. Patientnya kalau kasih consent buat CT, kita CT. Kalau nggak kasih consent ya kita nggak bisa.
Yeah.
Jadi kalau soalnya ada mass itu kan apa namanya is not an urgency, so I will do an MRI.
Baik, Prof. Silakan kalau masih ada pertanyaan. Ya. Kalau nggak ada, mungkin saya akhiri sesi tanya jawab ya. Jadi dari presentasi ini saya simpulkan, jadi CT scan abdomen penggunaannya cukup luas untuk imaging kasus-kasus di abdomen. Kemudian CT abdomen menggunakan radiasi yang cukup tinggi, jadi mesti perlu kehati-hatian untuk pregnan, kehamilan, sama yang punya risiko tinggi. Mungkin kalau nggak ada pertanyaan lagi, saya kembalikan ke host ya, Dr. Syanti Dewi. Terima kasih Prof atas presentasinya yang sangat menarik, Prof.
Kembali ya, terima kasih kembali.
Terima kasih atas lecture yang diberikan oleh Profesor Antoni, sangat luar biasa, Prof. Jadi mulai dari basic patofisiologi, kemudian kita diperkenalkan pada density Hounsfield. Sangat menarik, Prof. Sepertinya menjembatani mulai dari mahasiswa sampai para expert, para pengguna ya, Prof. Ya, untuk radiologi semuanya sangat interest untuk bertanya, untuk menggali dari Prof. Antoni. Terima kasih untuk Dr. Epri atas moderasinya, tadi sudah membantu kita untuk bisa lebih memahami lecture yang diberikan oleh Prof. Antoni. Kami persilahkan untuk serah terima sertifikat secara virtual kepada tim IT. Kami persilahkan. Certificate of Appreciation kepada Prof. Clinical Antoni Setiawan, Medical Doctor dari Universitas Katolik Widya Mandala, Surabaya. Kami sangat apresiasi waktu dan sharing dari Prof yang sangat berharga untuk kami semua. Berikutnya.
Kalau saya boleh, ada permintaan untuk record saya, apa ya, sertifikatnya bisa di email? Bisa,
Prof. Nanti kami emailkan untuk
sertifikat. Dan juga yang dari 3 minggu yang lalu mengenai ultrasound itu ya buat record saya, buat kenang-kenangan.
Kami emailkan untuk sertifikat 2 pertemuan.
Ya, oke. Terima kasih.
Terima kasih.
Coba ditampilkan lagi ya.
Dari tim IT mungkin bisa.
Ya.
Nanti kami follow up untuk email.
Ya, Profesor Antoni, once again, thank you very much for your presentation and sharing your experience to our medical students on behalf of Widya Mandala Catholic University, Faculty of Medicine. I would like to thank very much for you.
Hey, you're welcome.
To help us to make open-minded and so about the radiology and your experience and knowledge. Terima kasih Profesor Antoni. Saya kira tidak nanti kami akan kirim sertifikat ini, apresiasi kami, dan juga saya akan lapor pada Bapak Rektor bahwa kita telah dua kali mendengar ceramah atau kuliah dari Profesor Antoni, dan saya kira ini suatu hal yang baik sekali, dan saya harapkan semester berikutnya, bukan minggu depan tapi semester berikutnya, Prof. Antoni juga bersedia. Mungkin nanti kalau berada di Surabaya, Indonesia, saya minta juga kalau bisa juga memberikan kuliah secara tatap muka atau offline terhadap mahasiswa kami. Thank you once again. Thank you very much.
You're welcome.
Ya.
Terima kasih kepada Prof. Paul, Prof. Antoni, Dr. Puji Januartono, dan Dr. Eprianto. Sekarang acara kita lanjutkan dengan doa penutup. Kemudian nanti akan ada foto bersama. Pada saat foto bersama, kami persilahkan semua untuk membuka kamera kembali. Silahkan doa penutup untuk acara hari ini. Waktu kami persilahkan untuk Dr. Ivan.
Terima kasih Dr. Shanti. Terima kasih kepada Prof. Antoni untuk meticulous presentation-nya, sangat bagus. Menurut saya dan membuka wawasan saya. Mari kita bersama-sama berdoa untuk menutup mengakhiri acara pada pagi hari ini. Saya akan pimpin secara Kristiani. Mari kita berdoa. Ya Tuhan, terima kasih ya Tuhan atas penyertaan-Mu pada kami ya Tuhan selama acara ini berlangsung. Terima kasih ya Tuhan atas ilmu yang telah kami boleh dengarkan pada pagi hari ini. Kiranya ilmu yang boleh kami dengarkan pada pagi hari ini bisa berguna bagi kami ya Tuhan sebagai dokter untuk masa sekarang dan masa depan, agar setiap kali kami bisa mendapatkan pasien, kami bisa meng-approach pasien kami dengan lebih baik lagi ya Tuhan. Dan tolong ya Tuhan, bantu kami ya Tuhan, untuk selalu dapat bisa mengembangkan diri kami ya Tuhan, dan terus maju ya Tuhan. Dan kiranya apa yang kami perbuat ya Tuhan, kami bisa melakukan dengan yang terbaik, dan nama Tuhan boleh dipermuliakan. Selepas dari acara ini, kami akan melanjutkan aktivitas kami masing-masing. Tuhan, tolong ya Tuhan, sertai kami, lindungi kami ya Tuhan, apapun aktivitas kami. Kami serahkan ya Tuhan, acara kami selanjutnya hanya ke dalam nama-Mu. Amin. Terima kasih, Dokter.
Terima kasih atas doa yang dibawakan oleh Dr. Ivan. Baik, kita lanjutkan dengan acara foto bersama. Silahkan untuk dinyalakan kamera, dan kepada tim IT mohon diberikan aba-aba untuk pengambilan gambar.
Oke, mari kita lakukan foto bersama ya. Oke, 1, 2. Oke, sekali lagi. Oke, 1, 2, 3. Oke, kita cukup.
Terima kasih. Mohon izin, acara akan saya tutup untuk kegiatan essential learning role of abdominal CT scan for examination. Terima kasih kepada Prof. Antoni Setiawan, kepada Prof. Paul Tahalele, kepada Dr. Puji Januartono dan Dr. Eprianto, dan seluruh dosen, dokter, mahasiswa, Bapak Ibu yang telah ikut serta dalam kegiatan hari ini. Semoga apa yang disampaikan dan dibawakan bisa berguna untuk kita semua. Atas kesalahan dari ucapan, kata-kata, dan tadi waktu ada masalah teknis, kami mohon maaf mewakili seluruh panitia dari Essential Learning. Terima kasih, sampai jumpa di Essential Learning berikutnya.
Ya, terima kasih Prof. Antoni,
terima kasih.
Dr. Puji, Dr. Epri, Dr. Syanti, pembawa bicara para dosen sekalian, wakil dekan, dan juga mahasiswa yang saya cintai. Semoga ini berguna ya. Oke, terima kasih. Salam semua, salam sehat. Terima kasih. Ya. Ya, saya live ya, ada acara lain lagi. Ya.
Bisa ditutup dari tim IT.
Ya.